Okay, but, well, I just thought I'd show a couple of the things that I've done in the past for Karen, and it's a delight to be here again to stimulate you and entertain you. And I always seek some sort of artistic inspiration, and this is actually based on a talk that I gave originally in Ghent about 4 years ago. And I had this beautiful piece of graphics sent to me by the professor of O&G, and I thought I had to use that as part of the formatting. So this is my use. It took me ages to do that, by the way. So I'm going to be talking about BV, recurrent BV, and other animals, or more precisely, other microbes. And it's going to be a somewhat cut down lecture because I was going to put quite a few more things in it, but there are other bits and pieces of it that are actually online on YouTube, and you can always watch them because that'll allow you to get away for lunch much quicker. So here are my various different declarations of what I've been doing for the last 5 years or so since retirement. And so we're going to come back to this microbiome and also think of the immunome, which is another term that some people are bandying around, the various different things that we're going to be trying to discuss, or at least some of them will have time to discuss and others we won't. It's always important to start with what the normal cyclical changes are, what menstrual changes are, because I'm going to show you that in fact menstruation is a major driver of recurrent bacterial vaginosis. It tends to get better by itself, but it is something that does need to be taken into account. So we'll be thinking about what RBV, frequently recurrent bacterial vaginosis, which is enormously tedious for both the patients and for you as doctors trying to deal with it, and also how it relates to menstruation, how it also relates to perhaps covert endometritis and maybe hidden sexually transmitted infections, and also perhaps the male partner, more of which later. We'll also then have to talk a little bit about postmenopausal infections because the vaginal microbiome changes with lack of estrogen, and you get all sorts of different types of vaginoses that crop up. Now sadly in this talk there just isn't enough time. If I had an hour I would do recurrent candida and catamenial herpes. I don't know if some of you may have seen me lecture on these before, but I'm still probably the only person in the world that uses estrogen, transdermal estrogen, to prevent recurrent herpes in perimenopausal women, but that is another story and that is already online anyway. So let's focus then on the main event, if you like. Oh yes, Occam's razor.
What's that? What is it?
This is Occam's razor.
Occam's razor.
Occam's razor is a philosophical way of cutting through an argument to its simplest point. And here's my razor, which is that if you have any physical or mental symptom that has a precise repeating cyclical timing, it must have a hormonal cause. Is that logical or what? And therefore it could have a hormonal treatment. So that's my little razor for you, just for the fun of it. And so let's focus then on the normal cyclical and menstrual changes. And my good friend Phil Hay, who's perhaps one of the UK's top experts on the subject of BV, came up with this lovely paper, Life in the Literal Zone. Now, I used to work at both Bristol and Weston-super-Mare. Weston-super-Mare has the largest tidal range in Europe. And think of all the organisms that live in this literal zone, and they have to survive desiccation, flooding, all sorts of different heat and light and pH changes. And here's his lovely quote. I don't normally read quotes, but this is so elegant I'm going to read it. Given the dramatic environmental changes that occur over the course of menstrual cycle, it would be surprising if lactobacilli were able to survive every environmental insult in the literal zone, and they don't occasionally lose their plot in the ecosystem. That's what's happening in the vaginal ecosystem as well, causing dysbiosis. And also, of course, Alexander Sверzinski, who's really sort of set the bar very, very high, and with his research on biofilms. He's actually a gastroenterologist and very interested in the gut microbiome. But the great difference between the vaginal microbiome and the gut microbiome is the more organisms, the more variety you've got in the gut, the better, and the less variety you have in the vagina, the better. So that's what people want. So you've got this biofilm that's adherent to the vaginal wall, and that's where all the organisms are living. But also we now know, thanks to Alexander again, that this biofilm extends into the endometrium, and it probably has some relevance for IVF. We could perhaps talk about that over lunch because it is enormously important, but treatment of it may or may not be successful. So let's have a look and see where we go. Let's just think about the biofilm. As you increase the pH, you're more likely to get a diverse community from your original stable community of lactobacilli. You then get a diverse community, but if you can push the pH back by whatever means possible, maybe just by not menstruating, or maybe by giving things that acidify the vagina, or putting different types of probiotics into the vagina, or even eating different types of probiotics. Remember, of course, that there's a lot of transfer between the gut microbiome and the vaginal microbiome. So any of these things might make a difference here, but this is actually a very good paper that explains the relevance of the biofilm. So let's have a think about frequently recurrent bacterial vaginosis and become very, very, very simplistic about it. Most people say, let's just treat the symptoms. So what are you going to do? You're going to take metronidazole ad nauseam. Maybe you could actually advance it a little bit, use clindamycin cream instead, or even if they're getting regular, recurrent BV just after each period, or just the end of each period, you could drop them a couple of days worth of metronidazole. I mean, that does become rather tedious. It works, but it'd be very, very tedious. And there are all sorts of different things that have been tried. Which lactobacillus do you use? Acidic gel by itself, probably not useful. Probiotics, still, the jury is still out on probiotics, but almost certainly in the grand scheme of things, we're going to need to move away from just bunging antibiotics ad nauseam. So if you can get a probiotic solution, so much the better. Something that seems to work is acidic gel and glycogen, but once again, that you have to use that repeatedly to improve, to basically take the pH back to an environment where some of these organisms do not thrive, and the ones you want, the lactobacilli, do thrive. So now let's go 25 years ago. David Eschenbach, probably the time the sort of father of infectious disease and obstetrics and gynaecology in the States. And he showed that there was a tremendous variation in the normal flora, depending on where you were in the cycle. 4 times more lactobacilli just before menstruation, and at the same time, the other bugs are overgrowing. And of course, the pH changes during menstruation to be pH of blood, which is 7 or whatever it is. So you've got a pro-BV environment immediately after menstruation, and you've got less lactobacilli around because they don't thrive in that environment. So what you tend to get is some women who get recurrent bacterial vaginosis just for a few days around the time of menstruation. So they're above, if you like, the symptomatic threshold. And it's very important to remember this when you're trying to manage recurrent bacterial vaginosis. But that's an old-fashioned view of it, shall we say, 25 years ago. We've come on a little bit since then in our understanding. When I first saw this presented by Rebecca Brotman, who's, if you like, the second in command of Jack Revell's group in the States, and this is the longitudinal study of the vaginal microbiota. And she showed this one particular case where each month, every time there was a bleed, there was a change in the environment. So this is menstrually triggered dysbiosis, in other words, alteration of the vaginal flora, which spontaneously recovers, as you can see. Now, it is enormously complicated, and the reason we've got all these various different colours in the charts is because these are all the different types of organisms that were growing in one particular patient and another patient. Once again, in each of these cases, or more or less each of these cases, it's taking, actually this one, taking a little bit longer to get better, and I think this one was actually pushed into more continuous BV. But you can see in the first patient, pretty well every month she's getting a recurrence of BV organism. But they're different organisms because different ones are lighting up. Because when you've got all these tests that are being done, this is the original paper, the vaginal microbiome from Jack Revell. You've got all the different community state types that Jessica's already told you about. And the ones that we're interested in, well, the ones you should be interested in, of course, are the ones the good ones, crispatus and gasseri, and Jensenii, and to a lesser extent, Inus. The ones in the diverse group are the problems, and the A type, if you like, are the ones that tend to occur post-menopause and cause aerobic vaginitis, and the B group are the ones that tend to cause bacterial vaginosis. So once again, here's something that we did. I did with my former wife Annie Evans. We actually saw loads of women with recurrent BV in perimenopause. Now, if you take a perimenopausal woman, she's likely to bleed for longer, and also have a shorter interbleed interval, so she's got less time for the vaginal microbiome to re-establish itself. And what actually happens is, obviously depending on how heavily she bleeds and how short the interbleed interval actually is, she may be pushed over into more or less continuous BV. And we thought, well, the most logical thing to do here is to address the menorrhagia. And primary cause of menorrhagia, well, lots of different causes of menorrhagia, and of course, as a sexually transmitted infection specialist, one of the things that comes to mind, of course, is covert chlamydia, which is a major cause of undiagnosed menorrhagia. But let's just look at that. Think of how we could actually improve the situation. We took this idea that we would treat them all to make sure that they hadn't got endometritis, or at least screen them to make sure they hadn't got chlamydia, and then you could give a continuous pill regime, plus or minus metronidazole. Leaving the gestational IUS was the method that we thought would be the best one. We even got some improvements just on giving mefenamic acid. Astonishing, if you just reduce the amount of bleed, you will get an improvement. And so we thought this would be a logical thing to do. Nobody's done a randomized trial on any of this, except there was a trial in South Africa using Depo, and there was an improvement. So induction of amenorrhea improves BV recurrences, but it wasn't perfect. I mean, there was a reduction in recurrences, but not a complete ablation. Now, this isn't perfect work. It's a good theory, but there are certain circumstances in which it's been disproven by actually people doing the research, trying to use an IUS to reduce bleeding, and it works for some women and absolutely fails for a load of other women. So it's very, very individual. So let's think of some of these effects: endometritis, STI, whatever. Sorry, we're thinking now of covert endometritis, and we now look at this Danish infertility cohort. Very important paper, because remember that Alexander Svedzinski had shown that the microbiome extends into the endometrium. So it would be logical to see if an altered microbiome could be associated with a poor reproductive outcome, and it certainly is. And this superb prospective study, which is still ongoing, actually found we're looking at 84 women with an overall clinical pregnancy rate of 35%. But depending on whether your microbiome was normal or abnormal, made a huge difference to your clinical pregnancy rate at the first scan after IVF. And that's a huge, huge difference. So the logical thing to do, wouldn't it be nice if you could actually treat the dysbiosis and correct the dysbiosis? That seemed like a sensible thing to do. And this was published very, very recently indeed. And it's unfortunate that you take a group of women with abnormal vaginal microbiota and look at this wonderful name, Fannyhesia vaginae. I mean, where they get these names from? Who thinks up names like that? I really don't know. But anyway, there were a significant group of women that I identified with high loads of these particular organisms. And they chose to give them either oral clindamycin and lactin vaginally, clindamycin plus placebo vaginally, or placebo clindamycin and placebo vaginal treatment. And the outcome, sadly, no difference at all. So although there was a lot of hope behind this study and an awful lot of time and effort and money and grief behind this study, it didn't make any difference at all. Very sad. So we don't really know where we're going with that, I'm afraid, and we leave this to you guys to take it on and just keep fighting. There will be a solution somewhere. Some clever bastard is going to think of a solution to this, but they haven't done it yet. Certainly, I'm not going to do it. Anyway, I always fall back upon my good old friend chlamydia because there's a lot of it about. Wouldn't it be nice if you could just treat all the chlamydia and get rid of it? And of course, it's very interesting now that the Dutch have stopped screening for chlamydia in sexually transmitted infection clinics.
Why?
What? Stopped screening amongst asymptomatic women and asymptomatic men, because what they don't want to do is to treat a whole load of people unnecessarily, because the vast majority of people who are infected with chlamydia, it will resolve spontaneously without damage. So it's only if they're symptomatic that they're actually testing them. Now, there's a thought. However, we do know from this only one study has ever been done on this, looking at abnormal uterine bleeding. and endometritis, where they took historical endometrial biopsy samples and found that 52 out of the 65 had plasma cell endometritis, which is more or less pathognomonic of chlamydial infection. And when they actually did PCR tests, on these historical samples, they found that over half of the patients with unexplained abnormal uterine bleeding had chlamydial endometritis. Interesting or what? I don't think there's anybody in the world who's doing anything about that. So I think it's a jolly good idea to do this, but I'm going to tell you that it doesn't work. Because although we had some success with individual patients in front of us, we didn't do a trial, it was just patients with very, very huge notes, give them one or other of these treatments or a combination of these, and they didn't seem to come back. Now, of course, they might have just got fed up with us and gone elsewhere. We don't know. But when that work was done, using LNG IUS in Belgium by my very good friend Gilbert Dondas, he said that there were some women who did get better, but overall there was no significant improvement for many of these women. So we actually had a debate: is there some other factor going on here? And this debate, which took place a couple of years ago in Athens, we're both members of this ISIDOG, Infectious Diseases, International Society for Infectious Disease in Obstetrics and Gynaecology, and it was a very hard-fought debate, and I won, but I was wrong. Why? Because we now know, thanks to this is my good friend Gilbert that I'm just about to debate, but we now know that there is a male factor in bacterial vaginosis. Very interesting, very important. So what they did was they took a group of women who were in supposedly monogamous relationships and gave the men 12 weeks worth of metronidazole twice daily, no alcohol, how about that, and clindamycin cream on the penis, and looked at what happened to these. This was an open label study, obviously, and what they found was that there was a very, very substantial difference in the recurrence rate of BV between those where the men were treated and where the men were not treated. We know, for instance, there are many women who have one particular partner, and when they change partners or they go to one particular partner, they're more likely to get BV, and then they switch back to another partner and they don't get the recurrences. So what are the options? What are the options for the men in this scenario? So let's see how keen are the men going to be to collaborate with this. Okay, your partner has got recurrent BV. What are you going to do about it? Well, what's the first thing you could do? Well, how about that? You could abstain, couldn't you? Or you could be magnanimous about it and say, well, perhaps you ought to take a different partner. How many men are going to do that? Well, it could be other possibilities. Just take metronidazole forever, which means, I don't think in Australia this is going to go down very well. But the other thing that they could do that would definitely work is the one thing that all men are so keen to do, which is to get circumcised. Remember, there's very little of this problem, of course, in Israel. But anyway, that's another story. So, I can recommend that to you. Circumcision, jolly good, prevents HIV transmission as well amongst heterosexuals, but that's another story. Okay, so where do we go from that? Very briefly, we're taking up your time now. We're eating into lunch, so I know that we've got to finish fairly shortly. So we'll just do a little bit of a look at our postmenopausal group, and I thought I'd start with a typical case. We've got a 52-year-old, para 2+, married woman, married for 15 years. Actually, this has gone off the edge of the screen here. The menopause was age 48, so 4 years ago, and she's had 3 years of vaginal symptoms, and that she's been treated basically for recurrent thrush for all this time. She comes in with a shopping bag full of all these various different treatments, and we have a look at her, and we see that she's actually had this continuous itch despite all the treatments, and she's got introital dyspareunia. Now, we're looking very carefully at this. And there's quite a bit of erythema at the 5 and 7 o'clock position, so I wonder whether she had localized provoked vestibulodynia, but she didn't actually have that. If you look very, very closely, there's a tiny bit of white discharge. Tiny, tiny, tiny bit of white discharge. So we take our microscope and we have a look. And guess what we see under the microscope? Aha! Trichomonas vaginalis. Interesting. And we know that trichomonas vaginalis is more common in postmenopausal women than in premenopausal women. Now, why might that be? Let's have a look at the data. This is from Italy. They've got some very, very good people, gynecologists with specialist interest in sexually transmitted infections. They were getting out there with their microscopes. And this is the rates of Candida, BV and TB premenopausal, and in the postmenopausal age group, we see a completely different pattern. So what is it about postmenopausal women in Italy? Are they having more sex? Indeed, are their partners having more sex? We don't actually know what the answer to this is, because one of the things that has been shown, coming back from the meeting I was in Belgrade a couple of weeks ago, show that there's an excess risk of trichomonas in women in perimenopause and immediate postmenopause. And whether this relates to, this is a huge population study done in Belgium, done on cytology samples, interestingly, and they've surmised that this is something to do with what's going on in perimenopause. And it's not just the vaginal environment that makes it easier for trichomonas to grow, because remember, trichomonas likes a pH of around 5.5 or 6, and so it just means that the trichomonas seems to be more obvious, but maybe there's actually more trichomonas being acquired because of inappropriate management of perimenopause, antidepressants instead of hormones, relationship breakdown, people being back in the sexual marketplace. Who knows? It's multifactorial, but interesting. Okay, so oh yes, and another thing. This was the prize-winning paper from Johns Hopkins by Rebecca Brockman for that particular year, 2018. And what she did was to look at the menopausal status and see what the particular community state types were most likely to be. So premenopausal, it was state type 1 or 2 or 3. Perimenopausally, it was either the community state type 4A, which is the one that we're most concerned about, or L-Gasseri, and the postmenopausal was nearly all of them were state type 4A, the aerobic vaginitis type. So there's a 25-fold risk of an increase in the community state type 4 in postmenopausal women. And of course, much of that can be corrected with estrogen. And just to go over this is just a part of a lecture that I gave in Valencia at EMAS. Just a couple of summary slides from this. This was about the GSM genital urine symptom of menopause increases your vulnerability to sexually transmitted infections. All these different reasons, not just the changed microbiome, but obviously thin rugae, etc. And I'll remember, of course, the lubricants are important here. Just a quick shout out to Nick Pally and his team for people using the wrong type of lubricants can actually make it worse. So you have to find the right ones, and hopefully Jessica and company have got the right ones for you, or whoever else is providing them. Very important to use the right ones. But the most important take-home message from that particular lecture, and this is just coming up towards the end here. Oh yes. So is this? These women are back out in the sexual marketplace. This is late HIV diagnoses in Europe. The highest risk of finding people with late HIV is in the 40 to 49-year-old and over 50 age group. And in terms of the sexuality of the people in that group, the largest transmission group is men having sex with women, and heterosexual transmission of HIV is commoner in Europe than any other form of transmission. Because remember, of course, most or many of the gay men are either on treatment or on PrEP, and therefore they're not likely to acquire HIV. So the biggest risk of acquiring HIV in Europe now is heterosexual sex amongst women in perimenopause and postmenopause. Interesting, or what? So basically, that was my final slide. Just GSM care, just do it. So I don't, unfortunately, have time to regale you on the subject of catamenial herpes and recurrent candida. But if you want the lecture, it's actually on YouTube, and I gave it a couple of weeks ago in Belgrade. It's there for you. And once again, we don't have time, but I just thought I'd finish with another case, just for the fun of it. 54-year-old married woman, married for 12 years, and she's had 2 years of itch symptoms, and she's been diagnosed with candida on a regular basis. She's treated with fluconazole, and things get better for the time that she's taking the fluconazole, and a week or two after she takes the fluconazole, the symptoms come back again. You need to start thinking about what might be going on here. Let's just give you a few clues. She's got gingival recession and she's had multiple dental abscesses. Got any other clues? Oh yes, and she's got some oral candidiasis. I think we know what's going on now. And what's the diagnosis? HIV, obviously, because partner's been out in the sexual marketplace, or indeed discovered its true sexuality thanks to the internet and acquired HIV. And this is actually what we would now call a clinical incident. Certainly in many hospitals, if you miss a diagnosis of HIV that's as blatantly obvious as that, it's a clinical incident because that woman's at risk of infecting other people. Also, the lower her CD4 count and the higher the viral load when you see her, the poorer her long-term survival. Normally, you can pull somebody back with triple antiretroviral therapy, so not a problem. Well, that's about it. I think we need to just sort of calm down, get ready for lunch, and stop worrying about all these sort of things. And if you had just one sort of take-home message, once again, it's my razor of cutting across things to think you have a cyclical timing, must be a hormonal cause, therefore could be hormonal treatment. It's not the solution for everything, but it's something you need to think of, and so few people think about it. So your take-home message, if you like, is with recurrent vulvovaginal infections, don't just treat the symptom, but treat the cause. Think, is it cyclical? Not everything is cyclical, but it might be. But if it's not, what's the next thing to think of? Well, could it be that they're immunosuppressed? Or maybe, in fact, they've got untreated diabetes, or a whole load of other different possibilities, a lot of steroids. There's a whole list of them, but the one thing you've really got to do is to make absolutely sure that they haven't got HIV. You want to avoid a clinical incident. What else could it be? Could it be random? Could it be completely, could the recurrences be unrelated to their menstrual cycle? In which case, you've got to think, if you like, outside the box, what else could it be? And the one thing that I would like you to think about is the partner. Could it be a sexually transmitted infection? Could it just be sexually acquired or sexually related BV or not? May or may not be, but you need to think about that and do the screening and make sure you don't miss something that's obvious. Thank you very much.